my background actually is a this molecular study and of community transmission of TB, and also the using the modeling study to assess the impacts of the TB intervention from the national TB program. So this study actually was a collaborative studies between Stanford University and China CDC. And I will present the background analysis of this study, and Zexuan, my PhD candidates, he will present the main results and the discussion. And so China is a very huge country with big population. It's quite similar to India, and so it also have a geography heterogeneous. So the studies aims to assess the impacts of TB intervention strategy in China. So using and age stratified dynamic transmission model. And first of all, let me acknowledge the contribution from Mim. I mean, Mim is here today. It's very good. We actually have discussed this modeling quite a lot of times. But Mim, please, if you could explain some details, if possible, for us, it would be great. And also, Robert is from University, who is an economist, so he actually gave us a lot of advice from the health economic analysis. And Shitong is from Gates Foundation, and also my collaborator from director of China NTP, and also Li Tao is also from China NTP. So let me give you a little background. Over the 2 decades, China achieved very significant TB country progress. The incidence declined about 25% from 68 to 52 100 so population, and the mortality dropped to like 40%. It is driven by expanded diagnostic and the anti-TB strategy, start from 2016, 2017. And but if you can see here, actually, actually there's a quite a lot of prevalence and incidence was impacted by COVID-19. So after 2022 to 2023, so the prevalence incidence increase because of a symptom, because of actually a campaign of double funding, we call double funding, and that included active case funding and the COVID recover spree from the patients recover from COVID-19. And the TB burden actually was quite varied by regions, by province. So if you can see here, actually in 2023, 3% of the population belong to the very high burden of disease. That means above 150 per 100 kilometer. 100 human population, and I think now decreased to 1.2% in 2024. And then, if you can see, if the right fingers show you that there's quite difference in the western part of China and eastern part of China. The western part of China have like a 3 to 4 fold high disease burden compared with eastern China. And this thing shows actually we observed a very different, style of age-specific prevalence, not like other countries, especially in African countries. We have a very high prevalence in the elders, especially for the population aged above 65. we observed a very quick increase prevalence in this population, and we see there's a decrease for the population aged 65. It is most likely because of the limited sample size, because this data was from National Epidemiological Survey in 2010 in this line. And then I think compared with global average, and China have actually very low TB mortality, especially in the recent 5 years. We actually see a very quite difference with WHO estimation globally. And so this study actually we proposed three phase studies. First of all, we developed a dynamic transmission model, stratified by prevalence and actually a region. So we incorporating regional epidemic intensity, age structure, and population mobility. This model will clarify TB transmission pattern by quantify location-specific risk of progression from latent infection to treatment relapse. And then we will evaluate the effectiveness of single interventions and a combination of interventions. And finally, we try to conduct a cost effectiveness analysis across budget tiles. Using simulation and optimization methods, we identify the optimal intervention packages for high, middle, low resource settings. So the intervention diagram, this diagram was based on the natural history of TB after all the key stages of TB progression, and identifies interventions at each stage to prevent, diagnosis, and treat the disease effectively. So this diagram actually aligns with the natural history of TB from exposure to outcomes, and also highlights the target actions we may have to interrupt the disease progression. And so this is a model structure. This model is to simulate the TB natural history, as I said in the last slides, and the effects of specific interventions. And the traditional transmission dynamics model was extended to quite different compartments, actually totally 16 compartments. So the population is divided into compartments based on their disease stages. And the susceptible individuals here refer to the ACE, the ACE compartments who come into contact with asymptomatic and all symptomatic TB patients. They will transit into high risk LTBI, which refer to the E1. The E1 group transition to low risk LTBI at a specific rates if they, the 2 years later after they were infected. High risk group in E1 and E2 may undergo targeted infection screening. So, and also some of the patients accepted preventive medicine and complete it successfully, then move to the P compartment. But some of them, actually, this was just after discussion with me, we agree with his points. If they, successfully completed the TPT, they also have will move to the R1 compartments. And also, this model actually also include vaccination compartments that is V to simulate new vaccines effects. And all the population was divided in different TB high burden regions and different age groups, and it also be simulated to change over the time. And this is a compact formulation, and basically the contact matrix was was generated according to the different regions. And also the force of infection was calculated based on the I referred to the symptomatic active TB cases, and IS referred to the patients with recurrent active case, and also the asymptom cases and the cases they may require the retreatment of TB and drugs. And so here's basically all the epidemiological compartments and the description here. And this is for the epidemiological states compact formulation for the 16 compartments and the tracking compartments. I don't want to dig out so details. So just if you want to know in details, just let me know. And the model section, including the case, if they successfully receive TPT, they will exhibit better immune protection, but not so whereas normal people, they will just actually will go to the recover compartments, and the recent recovers faced high relapse risks, while treatment failure and relapse cases exhibited increase the risk of developing Japanese TB. And LTBI population actually are categorized based on the timing of infection, initial infection. That means if they are in the 2 years, within the 2 years of infection, new infection, they will present a high progression risk. But if they have 2 years later, they will decrease their risk of progression. And we actually assume that all the TB cases undergo asymptomatic TB stage, and compared to the systematic TB, the asymptomatic TB will exhibit low transmission risk. But for the relapsed TB, they remain equal risk of with the primary active TB. And so as I said, these slides represent our age and regional stratification. We divided TB burden region into 5 levels, from low to high, represent to like 1, 2, 3, 4, 5, 5, based on our TB incidence thresholds from 30, 50, 80, and 150. And the age groups were categorized into 3 layers, and below 15, 15 to 65, and 65. So our model actually used a dynamic population with age stratified population estimates from WHO data. As you can see here, like in 2024, and the highest burden region have like 1.2% of the total population of this country. And to address the aggregation of age-specific contact metrics across regions, we adopted a methodology from high-resolution human mixing pattern of disease modeling. So rather than a simple metrics addition, we classify prevalences by epidemic burden levels and construct age-specific, region-specific contact metrics that count for demographic variation. So we actually processed the 13 province. That means all the province in mainland China, and generate 5 regional contact metrics based on epidemic burden classification. So this model was calibrated against age stratified TB incidence data from 5 epidemic burden areas in China. The timeline was from 2010 to 2023. But we also, to do the adjustment for for the COVID-19 period, because we believe that it was being affected apparently by the epidemic. And for each era, the likelihood function incorporate three age-specific incidence time series and the WHO estimated total incidence. So we use the MCMC methods with the block updates and logs this participation to calibrate the model based on reported incidence time series. And also we combine agent-based modeling to simulate, which actually is a structured complex population construction based on the World Bank.
Right. Yeah, we just build an agent-based model to, there is a very complex like the risk population they are mixing in total total population. So it may be a little difficult to distinguish them and to uh, estimate the effectiveness of the screening interventions. So we built this uh, ABM submodel to capture the actual effectiveness of the active case finding for LTBIs for the close contacts for HIV infections and other risk populations. So we just we can see this slide. We generate our whole population uh, by the following four steps. First, we define the population by the year from 2025 to 2035. And also, we have distinguished this population and stratified them into 15 population groups. And then we allocate the risk labels, like the state for them, like the TB cases, asymptomatic TB cases, and also uh, the LTBIs with uh, high progression risk, like the lower progression rate, and also the recovers and HIV patients and diabetes and also the close contacts. And then we utilize two risk multipliers and one for the latent infections to and TB progression, and the other multipliers uh, for the for the active TB diseases, and they have two different risk to allocate the risk labels. And the following is the health economic evaluation method. And we have developed a comprehensive health economic evaluation framework, and including the epidemiological modeling results, the intervention parameters, the number of the the number of screening and the unit cost of interventions and treatments. And also we integrate our epidemiological results from the compartmental model and and some key epidemiological indicators included in the final results, like the annual treatment counts for drug-sensitive and drug-resistant cases, and the number of annual incident cases, the number of new TB infections, and also the number of deaths. And uh, then we integrated them with the intervention parameters, like the case finding number across the 15 population, and also the number of uh, LTBI screening and treatment, and also the screening coverage parameters in each population. And then is the unit cost structure. We just listed uh, the unit cost for LTBI screening, TBT treatment, and also the chest X-ray screening, and some some screening method for elderly, and also in the community, and that's 2025 RMB, and also the treatment cost for each TB case. And then is the method to calculate the total cost. We we needed to we needed to uh multiply our unit cost and the number of LTBIs and the number of TB cases and asymptomatic TB cases, and like uh, identify them by the drug resistant or drug sensitive, and to get the total cost of screening, and also the health economic benefit assessment. We uh we add three part of them. We consider the work loss of these patients, and the potential for the augmented LTBIs uh to develop to the active cases, and also the economic benefit from the uh, the averted gases. And also we conducted the a multi-dimensional ICER analysis, like for the daily saved, and for the economic benefit, for the averted TB cases, LTBIs, and the deaths. And we considered our analysis in two timelines, like the short term from 2025 to 2030, and the medium term from 2025 to 2035. And also we considered a 3% discount rate annual uh, for the health economic benefit. And also we calculated the benefit we received by the work loss time, and the uh, the GDP, and we considered a 4% annual growth rate for GDP. And this slide shows the scenarios we simulate. Like we first conducted the baseline scenario with no large-scale implementation of preventive treatment, and with the most case identified passively. And also, we then try to simulate the or estimate the effectiveness of single interventions we and the comprehensive intervention scenarios to uh, to try to simulate the strongest intervention packages. And also uh, in our last step to to try to optimize the intervention profiles. And in this slide, I would like to present the specific results of our current modeling work, including the parameter estimation, prediction of intervention effectiveness, and cost effectiveness analysis. And first, we can see this slide demonstrates the model fitting result for the 15 population groups and the WHO estimated incident cases. And as we can see, after switching to the trend-based modeling, fitting and constraining the parameter search range, we can see the blue estimate curves has aligns well with the uh, notification number of TB in the 15 populations. And also, we validate our estimates against WHO incidence data, and as shown by the points on this slide. And we can see that after adjusting for the underreporting rates, our incidence estimates align well with the WHO's estimates. And we can see the long-term baseline scenario pro, projections remains stable. And moving to our next slide on the intervention effectiveness, we can see our single interventions are categorized by some high risk populations, including uh, the population in the high burden regions, individuals with diabetes, HIV patients, close contacts, and the elderly and the recent recoverers. And the combining effect uh, of the screening, active case finding, and treatment from of these targeted populations, they form the strongest intervention scenario. And from we can first see the result from a national perspective. Our analysis reveals that most single population interventions show some limited effectiveness in reducing the epidemic burden, and however, there is a notable uh, intervention. We can see that the active case finding for the elderly has demonstrates significant benefits in the epidemic control. And yeah, and this slide we can see the relative reduction of incidence compared to the baseline scenario in 2035, and we can see that the we can see that uh, under the baseline under the baseline scenario, our model estimates the TB incidence rates will decline to 28.17 per 100,000 by 2035. And after implementing our strongest intervention scenario, can achieve a 49.9% reduction in incidence rates, bringing it down to 14.12 per 100,000. And also the targeted elderly active responder intervention alone could achieve a substantial 28% reduction, resulting in an incidence rate of 20.29 per 100,000. And we can also see the significant regional variations in intervention effectiveness across different epidemic burden settings. We can see that uh, there are two uh, there are two high-performing interventions across the five regions. The first, of course, is the strongest scenario, and also the active case finding for the elderly maintains strong performance regardless of regional burden. And also, we can see that the contact tracing and preventive treatment in the area one means the low burden region demonstrate a substantial impact. And also, we can see the effectiveness patterns across different regions. We can see the contact tracing and the TPT, and also the treatment management in area one can achieve 12.2% and 5% reduction in 2035 incidents respectively. And uh, we can see these effects significantly exceed those observed in higher burden areas. And also in high burden regions, the active case finding the in these areas can reduce the uh, 2035 incidence by 9.3%. And the next slide is uh, some CEA results. And we first conduct a comprehensive health economic assessment using the ICER analysis across the different regions and different timeline. And the first is the ICER heat map. We utilized four key effectiveness indicators. The first is the averted dailies and the averted deaths, the number of LTV cases prevented, and the number of prevented active TB cases. And we can see the white cells indicating the interventions that may achieve cost saving, and the lighter colors represent lower ICERs with more cost effective and they are the more cost effective interventions. And we can see that there is a significant temporal uh, cost effectiveness patterns is that the short-term intervention interventions gradually demonstrate higher ICERs compared to the long-term interventions. And also we can see in the medium border regions, the previous active case finding shows excellent long-term cost effectiveness, and also the some, and also in the lower regions, the ACF in the elderly, TBT for close contacts and HIV uh, can all can all achieve favorable long-term LSE profiles. And then it's our cost effectiveness scatter plot. We can see the bubble size represents the return on investment And also the color denotes the different intervention types. And then we can see that across all the regions, there are only two interventions demonstrate meaningful daily benefits. The strongest scenario and also the elderly target interventions. And we can see in the three intermediate epidemic areas, there are similar effective intervention profiles across these three regions. And also, there are limited overall ROI for the most interventions. But we can see the the active case finding in diabetes shows some meaningful daily recovery potential. And uh, there is still we can see in the area 5, the very high incidence regions, the strongest scenario can achieve relatively higher comprehensive effectiveness in these settings. And also, there are uh, there are relatively uh, enhanced ROI compared to other uh, regions. And this slide represents the results of our cost breakdown analysis for various interventions. It can be observed that the implementation of many interventions can gradually lead to savings in the total treatment costs. And and uh, and we can see that among the various interventions, the costs associated with those targeting the elderly and the type 2 diabetes patients are relatively high. And of these two, the benefits of conducting active case finding for the elderly are more significant. And we also conducted a regionalized analysis of health benefits forest. We can see that expect in areas with extremely high epidemic levels, the combination of ACF for the elderly and the strongest intervention measures has a significant effect in reducing TB cases and LTBI. Well, the benefits of active case finding for the elderly in extremely high epidemic areas are not significant. Uh, Additionally, contact tracing and preventive treatment in very low uh, epidemic areas and active case finding for previous TB patients in high epidemic areas show some benefits. The treatment management has limited benefits in reducing incidence and the number of LTBIs, but contributes significantly to avoiding deaths. And lastly, the return on investment analysis for various types of interventions shows that the close contact and the active case finding and LTBI screening and preventive treatment for close contacts and HIV patients. Due to the savings in the treatment cost yield negative ROI results, making them worthwhile interventions to implement in areas with very low and very high epidemic burdens. Additionally, the case finding for the elderly in very low epidemic areas, uh, the close contacts and HIV interventions in the three intermediate epidemic burden areas, the case finding for previous patients in high and very high epidemic areas. And the strongest intervention combinations can all achieve favorable investment returns. And this shows our future research direction. First, we will continue to improve the CEA of various interventions. We will first refine the baseline parameters and the interventions for each region, not only targeting the population, but also detailed the interventions. And also, we will uh, try to enhance the LTBI screening and the GPT simulation methods and conduct CEA for our medium and long-term planning scenarios. And then we will conduct the optimization scenario exploration uh, after the CEA of strongest scenario. We will rank the cost effectiveness of the more detailed single interventions and conduct the optimization scenario exploration under the limited funding levels until the investment exhausted. And this concluded our presentation, and we look forward to your constructive feedback and suggestions. Thank you.
Thank you so much, both to Professor Wang, who's, I believe, back online now, and to Dr. Zexuan or Professor Zexuan for taking over so ably. That was a really detailed analysis and really, really interesting to see. So thank you so much for that. Do we have any questions? I know I have a couple, and I guess maybe while we wait to hear from others, my first question is, I slightly lost track of what the strongest intervention scenario was, and I was wondering what that scenario was compared to the other interventions, because I think the way I interpreted it was essentially a combination of all of the other interventions. But then I didn't quite
Yeah.
see how it added up to have so much more effect. So I was just wondering if you would, and apologies because I think you did go over that, but I just had lost track of that by the time you were showing the results.
Yeah, I think actually as uh we introduced, we can see the strongest scenario is the combination of the interventions of the single population. And because of the use of the uh, agent-based model, we can it's not the simple addition of these other seven interventions. It's the like the we considered the mixing of these risk labels in the population, and uh, uh, I think it's obvious the strongest scenario. Maybe uh, mm, it's not we it's not the we can see the effectiveness of the the strongest scenario is it can exceed the the addition of the effectiveness of the other interventions because of the and also because we considered the mixing risk of the population. So I hope I hope I have explained the question.
Thank you. Yeah, and I see Professor Wong in the chat has also said that there's the overlap between the high risk groups, so you can sort of be
Yeah,
targeting individuals across those. I think like sort of area 5 is maybe a good example of that, where I was surprised at quite how much more if relative reduction you get from the strongest scenario compared to all of the individual scenarios. I don't think I haven't quite followed that, but I think that's just my my lack of understanding. But thank you. It's an interesting one to
yeah,
see.
thank you.
Questions from other people? Anybody? I also maybe when you were talking about your so you have these different regions and you were talking about the contact matrices within the regions, but I wasn't quite sure.
Yeah,
I don't think the regions aren't linked in any way. Is that correct? I wouldn't expect them to be. There's so much detail going on here already that I think to add, some form of migration or meta populations that interact would
yeah,
be really complicated. But I just wanted to check that's correct. They're not linked through transmission or anything. So it's essentially sort of different models for each one that are running in isolation.
yeah. We also considered it as a very uh very important consideration. Uh, uh, from our perspective, we wanna try like a more simple and a better way to simulate the the connection of each regions. But as we can see, we have categorized the whole population into five epidemic burden, and we the the notification number we used to categorize them is the notification rate in each country. So I think the regional the the regional distribution of uh, the of each country in the same epidemic area may be very complex. So we just want to try a, a way to uh, simulate this complex scenario. Thank you.
Yeah, absolutely. I mean, I can't think of any models off the top of my head that do, for TB at least, that do that sort of meta populations joined up. That definitely adds a whole nother level of complexity. But that's interesting to hear. Thank you. And maybe, I mean,
Yeah,
you were
thank
talking
you.
about the calibration to notifications. When you first talked about calibration, I got the impression you calibrated to incidence estimates, but then the fit to notifications was really good. So did you calibrate to both incidence and notifications, or just one or the other?
We conduct the calibration with the notification number of the Philippine populations and also the incidence number from the WHO's estimates in the same time.
Okay, brilliant. Thank you. I think I misunderstood earlier in the talk. Thank you. Does anybody else have a question? We've actually only got like a minute or so left.
Let me
So,
add some to the calibration, because we also use the underreport rate to adjust the the number of notification, which we, especially for the COVID-19 period.
I have one question. Can I? Hi,
Please, yeah. Please go. Please ask, Sandeep.
Oh, it is a really complex model. Means so many things together in the model. I understood how the complex would be for calibrating and all these things together in different ways. So I have technical questions regarding the age categories. As per my understanding, there are 3 age categories you consider for this model, right? So what is the rate? How do you consider the rate of transition from one age category to next age category? I mean, what is the rate of transition there? Means from one age group to next age group. There is some people are growing, right? So how these are being done, considering
Yeah, we just we can see that we set 3 age groups in each region, like under 15 years and from 15 to 64 and 60 and 65 and above. And we just set a growth rate in each age group. That's the average uh, uh, the average time they spend in each group, like the average time they take, and we
okay,
set it as the growth rate.
okay, thank you. Yeah.
Thank you. With that, I think we've actually run out of time. But thank you so much. I agree with Sandeep. It was a really complicated, with a lot of considerations in there. So really interesting to see, and I definitely look forward to reading if this comes out of the paper. So thank you so much again for such a great presentation. We at the moment don't actually have a presentation in August. That's summer holidays here in the UK and across much of Europe and the US and elsewhere. But we will be aiming to come back with a seminar in September. But so hopefully we will see you all then and at the union as well. Thank you so much again, Professor Wang, and to Zexuan for taking over as well. Thank you, and see you all.
Thank you. Thank you, Pina.
Yes,
Thank you,
very
Bye,
everybody.
bye
much.
everyone.
Bye.